what I'm already talking about, feel free to stick your hand up, and I'm happy to skip it. And there might be some stuff that I cover that Calvin also covered, so I'm happy to skip that as well. Okay, and my name's Evan, so it's nice to meet you all. All right, so what are we going to go through? So we'll go through some anatomy, which is everyone's favorite, physiology, and physiology is quite big, but it's really crucial that you understand it. Pharma is quite simple, and that'll just be a one-slide thing. And then I'm going to spend quite a bit of time on clinical diseases, and I'll also cover clinical skills. So we'll go through the renal history, the renal exam, and then also some things that came up in OSCEs in previous years. And I've put acid-base balance separately because, again, big topic, and it's important that you understand it. Okay, so starting off with anatomy, we'll start off like really broadly. Kidneys, they're retroperitoneal, and they exist at different levels, and we'll go through that on the next slide. And really, they're important for three things. So they're important for filtration, so taking out any toxins, reabsorbing any important ions, and then excreting toxins as well. So where they lie is quite important. So they're situated at the back and the flank, and they're at in between T12 and L2 and L3. And the reason why your right kidney sits lower is because you have your kidney in the right, your liver in the right upper quadrant, and then that pushes it down. And why that's important is because if someone gets stabbed in the back at their costovertebral angle, the right kidney is more likely to get damaged. So your blood supply comes off the renal artery, and that comes off your abdominal aorta, and that's just distal to your superior mesenteric artery. Where the lymph drainage is, so that's your para-aortic lymph nodes, and why that's important is so if you have carcinoma of the kidney, that's where you would expect the cancerous cells to migrate to. And another really important fact is that the renal arteries are anatomical end arteries. So what that means is if you get any type of infarction, there's no anastomosis to cover the blood flow. So now the arterial supply. So pretty much just remember that mnemonic. It's not that important when you get to clinical years, but for preclinical, they love chucking in some really kind of niche anatomy questions. And then you've got your venous drainage. So again, right renal drains directly into your inferior vena cava, but the left renal vein has tributaries. So it also drains the left testicular and the left adrenal. So I'm just going to quickly go over the bladder because this is important for disease. So you've got three layers of the bladder. Importantly, the muscle in the bladder, the smooth muscle, is the detrusor muscle. And then you've got it lined internally by this transitional epithelium. And it's transitional because the bladder obviously needs to expand and contract. And the way the detrusor muscle works is it acts as a functional syncytium. So what that means is when it starts to contract, the entire bladder contracts as a whole. And it does this histologically through gap junctions. And when contracted, the bladder can reach quite high pressures. So just going to the ureters, so again, they're retroperitoneal, and retroperitoneally, they're the only thing that runs from lateral to medial. So that's quite easy if you're looking at like a cadaver and then you want to see what the or which structure is the ureter. And they run posterior to your renal artery and your renal vein. And then lastly, the ureter pierces this detrusor muscle in a way so that it enters obliquely, so that when the bladder contracts, it also kind of squeezes the tip of the ureter, and so that prevents urine from going backwards. And that's important because as you get older, or especially if you're a young child, the angle that enters is different, and so you can get urine going the wrong way up the ureter, and then that can lead to infection of the kidney, which is pyelonephritis. And now just quickly going through some innervation of the bladder. So this is quite a big slide, and you might need to look at it in your own time to kind of unpack it. But it's talking about how you've got your sympathetic and your parasympathetic innervation, and they actually do, the opposite of what you would think. So you've got your sympathetic, which relaxes the bladder, and then you've got your parasympathetic, which causes contraction of the bladder. And then obviously you have your somatic neurons, and they're what's involved in the external sphincter. And then lastly, you've got your bladder emptying. So you've got signals from the brain. They inhibit the sympathetic, and then that stops the sympathetic inhibition of the parasympathetic. And then you've also got denervation of the somatic system, which then relaxes the external sphincter, which allows you to go to the toilet. So I guess, does anyone have any questions on the anatomy at all? Happy for me to move on to phys? Okay, so we'll start off by just talking about the extracellular matrix. So you've got your cations, and the major ones extracellularly are your sodium and your chloride. And then you've got your major cations inside the cell, and that's potassium. And the major negative one, obviously, phosphates. So the osmolarity is generally 280, and that's the same for your plasma. So we come to this idea now of Starling forces, and they become important really for not only the kidney, but also the heart and also the liver as you move on. So it's really this idea that you have these different kind of pressures, and those pressures act on a closed compartment. And then this can lead to the movement of blood within the compartment, but also the movement of fluid outside the compartment. So you've got this idea of hydrostatic pressure, and that's really the pressure generated by the heart. But then you've also got your colloid osmotic pressure, and that's the pressure that's generated by the albumin that's in your vessels. So what can happen is in certain diseases, you can get low albumin in the blood. That will change the oncotic pressure of the blood, and that leads to water moving out of the vessel compartment, causing edema. So that's why it's important to understand this net driving pressure that the body works on. And then moving this further into the capillary, so like I said, you've got this net filtration pressure in the kidney, and the difference in the kind of hydrostatic pressure on one side and the hydrostatic pressure on the other, with the colloid osmotic pressure of both sides, will then affect the net movement. So really, the way to think about it is you've got kind of like, you've got material that needs to get into the Bowman space, and you've got competing forces. So really all this is trying to say is if one increases or if one decreases, then the net movement will change. And by understanding the Starling forces, you can be given a disease state, and then you can predict where the movement will be. So really now we come into how is this extracellular fluid monitored. And there are four main ways. So you've got your baroreceptors, and they deal with pressure. You've got your osmoreceptors in the hypothalamus, and they deal with the osmolarity of the blood. Then you've got your renal baroreceptors, and this is the RAAS system. And then you've got your adrenal cortex, which I'm sure Calvin would have discussed. And this is all about aldosterone. And really, there's two ways in which changes in the extracellular fluid volume are kind of monitored. So you've got your baroreceptors in the aortic arch and in the carotid artery. And then you've got stretch of your ventricles, which release your atrial natriuretic peptide and your brain natriuretic peptide. So BMP is also released by the atria. And then again, you have your renal baroreceptors, which we'll talk about a bit later. So now really just talking about GFR and the filtration fraction. Really just know that GFR is just the amount of something that's moving through the glomerulus. And then your filtration fraction is just saying out of everything that's moving through, what is that as a percentage compared to the renal plasma flow? So structure of the nephron. Do you guys know this pretty well, or do you want me to go over it? Sure. So the nephron really, so it starts off in the cortex. So the kidney is divided into the cortex and the medulla. And it's really your loop of Henle is the only item of the nephron that extends into the medulla. And it does this because you have different gradients of salts. And so this is what facilitates the exchange of water. So now we'll just go through the general pathway to urine formation. So you've got your afferent and efferent arteriole. So they bring in blood and take away blood, which ultimately aims to be filtered, really. And there's three things, again, that happen. So you have filtration, secretion, and absorption. And that equation at the bottom will give you the urine production. It's pretty good. We'll go through that. Okay. So important histologically, as well as in disease states, there are three layers to the filtration barrier. So first, you have your endothelium that's fenestrated, and then you've got your basement membrane and the foot processes of the podocytes. They're quite important because they're negatively charged, and you'll probably remember that protein is also negatively charged, so they repel each other. And this is really the barrier that stops blood from getting into the urine, and also stops protein from getting into the urine. So as we'll talk about later, with certain conditions, you might have blood in the urine, you might have frothy urine, which means you have protein in the urine, and they will become important when you're trying to figure out the disease process. And this picture, again, is just showing you those Starling forces, so showing you that there's this capillary hydrostatic pressure, and both have oncotic pressures, but because they're different, the net filtration is towards Bowman space. So now we're just going to talk about, so we're going to put together the Starling forces and try to think about how that can change the GFR. So we'll start off now with, say, a glomerulonephritis. So it's just a condition that causes thickening of the basement membrane. So if we have thickening of the basement membrane, and if our hydrostatic pressure in our afferent arteriole stays the same, then it's harder for stuff to move across the basement membrane, and so that filtration rate will decrease. So can someone tell me what would be a compensatory mechanism of the body to increase the GFR, knowing that the basement membrane is thicker, and we really only have one thing that we can change? Did someone say blood pressure? Yeah. So hypertension is one of the things that you'll see in someone that has glomerular membrane disease. And I guess this is why it's important. So with med, like as you move on, it's going to be pointless just memorizing facts. Yeah, it's better to learn stuff like this, like the first principles, and then that way you can apply it to anything and it will make sense, usually. So with kidney stones, this is just a mechanical obstruction. It's the same thing. So now, say we have a kidney stone, it's in the ureter, it's banking up things into the kidney. Now that capillary, sorry, not the capillary, but the hydrostatic pressure that's in the Bowman's capsule now increases because we've got a backflow. So now, because of that, and because the blood pressure is the same, GFR decreases again. And then the last one I'll talk about is liver disease. So in liver disease, you have low albumin because the liver makes albumin. And because of that, your colloid pressure changes. So you actually get an increase in GFR. Okay, so now we're talking about control of the pressure. So we've got afferent and we've got efferent. And really the easiest way to think about this is just to think about it as a straight line and a pump. So if you increase the diameter of the afferent, your rate will increase because more blood is going in. If your afferent stays the same, but your efferent increases, then the GFR will decrease because you're having a lower pressure on one side and less blood going in. So really, all you're thinking about is if you're constricting blood to it, there's going to be less blood and less pressure, and then the opposite will hold true. And why this becomes important, though, is because later when we talk about pharmacology, there's going to be something that we talk about called the triple whammy. So this is 3 drugs that a patient can easily be on that can lead to a acute kidney injury. And the reason it happens is because it constricts various points of the kidney capillaries, so leading to no flow. No idea. It's from a lecture. I just know GFR. Sure, that makes sense. Go with that. Okay. So this slide is talking about vascular smooth muscle and the RAAS system. So what happens? So really the RAAS system is a way in which to increase pressure after a low pressure onslaught. So if we have a decrease in our blood pressure, it means that we have a decreased GFR. And that means that there's a reduced blood volume that's flowing past the macula densa, which also coincides with the reduced concentration of NaCl. This then leads to release of renin. Renin will release angiotensin II. Eventually, it will cause an increase in angiotensin II. And this changes the resistance of the efferent arteriole. So by increasing the resistance of the efferent arteriole, that will then increase the GFR. And this is known as the tubulo-glomerular feedback mechanism. Probably not really that important for exams, but again, good to know. Renal clearance, I'm not really going to go through this. I've just put this in for completion. And now we've got transport in the nephron. So I'm going to start with the next because we're going to go through the actual segments. So as you can see here, most of the sodium is filtered in the proximal tubule. And then generally the rest is in the ascending limb. So this is where the pharmacological action of drugs will become important as we move on to pharmacology. But this is an important one to know. So the majority of sodium in water is filtered or absorbed, should I say, at the proximal tubule. And now what actually happens there? So really so on each of the following slides, it's the type of cells that are in each point of the nephron and why they cause different things to be absorbed and different things to be secreted. So here it's just talking about how Na is actually transported. So it's co-transported with glucose or an amino acid. And then you can also have exchange here of hydrogen, so that can change acid-base balance. Now going to the loop of Henle, you've got your descending limb and the ascending limb. So the descending limb, really there's no brush border and there's few mitochondria, so that's important for histology. And really this is what's allowing the water to leave and creating that gradient. And here you have about 10% of water absorbed, but there's no active Na absorption. And you can get the diffusion of urea and sodium here. Then you've got the ascending limb. So that's really where most of your NaCl in the loop is absorbed, along with potassium, calcium, and also bicarb. And now you've got your collecting duct. So the collecting duct and the distal convoluted tubule are important, mainly because this is where aldosterone, antidiuretic hormone works. So the way ADH works is by increasing aquaporins, and aquaporins absorb water, leading to a more concentrated urine and a higher kind of fluid load in the body. And I think Calvin's already gone through ADH, so I'll skip this for time. And aldosterone and the adrenal cortex layers. Okay. So factors controlling your renin release. So again, you've got your renal baroreceptors, which work on your blood pressure. And then you've also got your sympathetic nerves, which will increase the release of renin. And now you've got two stimuli that control thirst, which is important. So you've got dehydration and a decrease in blood volume. And contrary to belief, it's actually the dehydration is a much more sensitive measure of stimulating thirst compared to losing blood. And that's because you need to lose quite a lot of blood in order to stimulate thirst, but you don't need to have much of a change in your osmolarity to stimulate the the chemoreceptors in the hypothalamus. And lastly, this is just how ADH works, so you can see aquaporin 2 there on the surface. Again, this is how dehydration causes an increase in ADH and how blood loss leads to a change as well. And we'll go through some fluid states in a bit. So really, heart failure is just putting it all together. So we'll try and put together the stuff that we've talked about and talk about why in heart failure you get fluid overload, because the kidneys play a big part in that. So have you guys done much of heart failure this year? Oh, last year, perfect. Okay. So when you have heart failure, you have this reduction in your left ventricular ejection fraction. So it just means that the heart isn't pumping out much blood. And because of that, the kidneys get a low pressure flow. So they're getting low blood pressure to the kidneys. And the kidneys actually think that there's not much volume in the body. So what they do is they stimulate the release of renin, they stimulate the release of aldosterone, and they cause increased firing of the sympathetic nervous system. And what this means is that the body starts absorbing sodium, and as you all know water follows sodium, so you get this increase of water in the body. And it's because of that the body retains more water and you get this edema. So that's why this chronic kind of hypotension and hyperperfusion leads to you absorbing more water, and then this can in turn lead to renal failure. So these next two slides are just in for completion. They're more just for your understanding, and they kind of drove this into us a lot last year, like what would happen if you drank a liter of water versus if you drank a liter of isotonic saline. And really it just has to do with where kind of the fluid moves in the different spaces. Okay. This one's quite a dense slide as well. So this is really just talking about why you feel the need to go to the toilet. And it becomes important though later when we talk about the different conditions that can happen to the bladder, depending on what kind of neurological change you have and how that can lead to incontinence. So really it's just saying that if the bladder didn't respond to pressure, then every time you had a little bit of fluid dripping in through your ureters, you'd need to go to the toilet. And that would be obviously annoying. So you need to have a certain pressure reached before your parasympathetic system is activated and before you empty the bladder, because there also needs to be a certain amount of fluid in the bladder to ensure that when you do void, that everything is cleared. And this will make more sense later, because there's a certain condition that you can get because of damage to your spinal cord that leads to an incontinence that means that your bladder never voids properly, and that predisposes you to cystitis, so just inflammation of the bladder. And really, pharma is just explained by one slide, and 5 kind of drugs affecting 5 different points. So I guess the main kind of but the thing is, as you kind of make changes to get rid of water, then you also affect certain ion concentrations. So the main one that I would kind of know for you guys would probably be your thiazides, your loop diuretics, and your spironolactone. So we'll go through it. We'll start off with furosemide, which is just number 2. So pretty much because a lot of the sodium is absorbed in the loop of Henle, you can change the absorption of sodium, you can reduce it, and by doing that, you can cause increased release of water in the urine. But one of the things that happens when you do that is, obviously you will reduce your serum sodium because you're affecting that pump. And then that pump is the sodium potassium chloride pump. So if you stop that pump, you're also going to be excreting potassium, you're also going to be excreting chloride. And because of that, you're going to lose all those 3 ions. Another thing as well is, I have this, I have an updated presentation on my drive, which I'll give you the link for, but I have a couple more other slides talking about some other things that can happen and some other side effects. Most importantly though, with furosemide, when you affect these 3 ions, you also affect the movement of magnesium, calcium, and phosphate, because these 3 ions kind of also cause the movement of those 3 ions. So by getting rid of the pump, you also affect the other 3, which is important to know. Then you've got your thiazide diuretics, so they basically stop the NaCl pump in the distal tubule. And again, it's a very common diuretic that's used. And then you've got your spironolactone. Spironolactone inhibits aldosterone. And because of that, you absorb less sodium. Okay, so we're going to go on to clinical skills and diseases. Give me one sec. Okay. So do you guys want to take a 2-minute break? I'm just going to log into my drive quickly because I've got an updated slide that you should probably see. All right, so maybe we'll just get started again, just so everyone can go home soon. Okay, so there are kind of some side effects to drugs that you just need to memorize for your exams. So I've kind of put the main ones, the main three, on the right-hand side there. So you're going to hear a lot about mannitol. Mannitol is not really used in the hospital as a diuretic. It's more for like edema that's localized, so like say periorbital edema, so that's when you'd use it. Your side effects of your loop diuretics, so you've got increased uric acid, which can lead to gout. You've got ototoxicity, so your ears, and then you've got this loss of ions, and then your thiazide diuretics have their kind of very common toxicities. Give me one sec, sorry. All right, so your renal history, I can't really tell you much about this, just remember the mnemonic. And now we'll just go through some things that are commonly missed in the renal exam. And they're things that you really don't want to miss because they're just easy marks. So kind of never forget the general inspection, and never forget what you're looking for in someone with kidney disease. So, comment on the fact that you can't see IV lines hooked up to them, or you can't see a dialysis machine. You're never going to see it in an OSCE, but it's what they want to hear, right? Then the second is always comment on the patient's alertness and cognition when it comes to renal, just because when you have a buildup of uremia and ammonia, you can commonly get encephalopathy. So that can make you quite confused. Always comment on the vitals, and just get into the habit of saying it. Also, looking for asterisks. So I don't know if you guys know what they are, but like if you ask the patient to put their hand back, they can get a flap. And that's because of the buildup of either ammonia or carbon dioxide. Then just looking at the face and commenting on malar rash. So why would you say that? Because if a patient does have lupus, then they can commonly get lupus nephritis, which is important. Kind of never forgetting the chest. It's an easy thing to miss with renal because you don't really usually pair the heart with the kidneys, but a lot of things can happen if you have fluid overload. Also, not forgetting the back, so the Murphy's punch sign to look for pylo, and then abdo as well to look for ascites. And lastly, everyone always forgets conclusions and further tests, which is quite important. So looking at the fundi for changes that happen to the retina in diabetes, and then also just monitoring their blood pressure for hypertension, and doing peripheral neurological exams as well. So now I'm kind of going to go through urine analysis because this is quite important for an OSCE station. So, you start off by doing, your normal kind of introduction, date of birth and all that jazz. So next now you're going to interpret the urine. So if you go through this kind of systematic three kind of step way, you won't forget anything and you'll guarantee that you get the full marks. So the first thing you're going to do is you're going to look at the color. So, is it red to indicate blood? Is it kind of coke colored to indicate red blood cell casts? Odor is a weird one. Just don't smell it. But like with certain conditions, if you do open the lid to do the urine dipstick test, you might smell like an ammonia smell or something like that, which you can comment on. And then lastly, like looking at the clarity. So is it opaque because of infection? And again, is it colored again? And also one to put in is, if it is red, is it because of beetroot? An important differential. So then you're going to look at the strip results. So what do they mean? So if there's sugar in the urine, the thing you're thinking of is diabetes, obviously. Looking at the pH. So if it's alkaline, then you're more likely thinking about a UTI. And the confusing thing is, like, a lot of the time you can go to the shop and you can buy this thing. I think it's called urease. I can't remember what it's called, but it's supposed to stop UTIs and it makes your urine more alkaline. So I don't really know how that works, but apparently if your urine is more alkaline, then you're less likely to get a UTI, but having alkaline urine is a sign of a UTI. Go figure. And then also just commenting on the fact that they could have ketoacidosis or an acute kidney injury. So do they have protein as well? So could it be a nephrotic syndrome? And we'll go through them in a bit. Do they have white blood cells to indicate infection? Do they have ketones? And ketones can really happen because of two reasons: diabetes or starvation. You wouldn't be doing a dipstick on someone that's starving in an OSCE station. Then again, are there red blood cells there, and is there hemoglobin to indicate hemolysis in the blood? And now I'll just quickly run through the midstream urine. So the reason for that is you're just trying to get a clean catch of a specimen of urine in order to send it off. And I suppose the most important things is to explain to the patient that obviously there's no harm, but in saying that, it's really easy to be like to the patient, oh, don't worry, there's no harm to you. But if the patient's a 92-year-old woman that's slightly kind of confused, you're probably doing harm making her go and do this test herself. So they're just things to think about to show the examiner that you're actually thinking through the station. As well, the procedure is quite important, like how you're going to clean it. A lot easier to explain to a male compared to a female. So know kind of your anatomy and know how to explain it. And also just telling them that they need to void a little bit first and then catch the specimen. And tell the patient to label their details on the container before you do this. Then right at the end, the main two things is just check the specimen and make sure that you can still read their name. And the main thing is gloves go in the waste bin, so not the colored bin. So often in OSCE stations, they'll have kind of like the biological hazard bin, and then they'll have the waste bin. So urine is sterile, so you don't need to throw it in the biological hazard bin. Okay, so now we're nearly done. So we'll go through nephrotic versus nephritic syndromes. So this is really a way to kind of divide kidney injury. So the way to think about it is the 3 O's and then the 3 H's that I can see, and we can talk through that. So with nephrotic syndrome, you have proteinuria because you have protein leaking out. You have hypoalbuminuria because you're losing protein in the body. And the reason why you have hyperlipidemia is because when the liver senses that you have low albumin and you're losing proteins, it starts secreting lipids. And that's the reason why they have this. Now, when you compare this to and nephrotic syndromes happen because you get damage to the podocytes, so you're leaking protein. With nephritic syndromes, though, they happen because you get damage to the fenestrated endothelium and to the basement membrane. So in these patients, you're going to see hypertension, you're going to see blood in the urine, and this will comment, the Monash buzzword is red, Coke-colored urine. So you're going to have red cell casts in the urine, and the patient is going to produce hardly any urine. So they'll have oliguria. And really kind of this picture sums it up pretty well. So if you kind of just remember the 3 things for each, you should be able to work out any condition. And then running through acute kidney injury, so you've got 3 kind of ways that it can happen. And this is based on where it affects the kidney. So you can have your pre-renal, your renal, and your post-renal. So pre-renal, really, the only thing to remember is it's just low pressure, low volume, low perfusion. Renal, direct damage to your kidneys, so your drugs, your glomerulonephritis, and your interstitial nephritis. And then post-renal is really all about kind of either a bladder injury, either prostate cancer, or a stone that's causing a block. So really, I've just put in now the signs and symptoms of an acute kidney injury. I don't think this is relevant for Year 2. I've just put it in there because it might help you kind of understand how a patient would present. And now really just talking about chronic kidney disease. So this is commonly seen in diabetics. That's the #1 cause. So all it's really saying is you're having damage to the kidneys, and this damage is shown and it's marked for greater than 3 months. The most commonest causes are diabetes and high blood pressure. You'll remember, if you remember back to your Year 1 lectures, these are 2 out of the 4 kind of things that involve metabolic syndrome. And they're also very high risk in people with cardiovascular risk factors. So if you are doing an OSCE station, it's a cardiac station, and your patient, has diabetes, has high blood pressure, has high cholesterol, this is a really good thing to comment on, so that you want to watch their kind of EGFR to watch their kidney function. And it's such a bad disease because it's usually left too late, because really it's asymptomatic, and the only way you pick it up is if you did measure the EGFR on a lab study. And really, this is just in for more completeness. Just know that until you get up to really moderate to severe, you're not going to have any symptoms. And the way that the patient commonly presents is just that they're tired. So they're tired because they've got an anemia because of decreased EPO. They might be quite edematous, and that's because they'll have this salt and water kind of retention that we talked about before, as the GFR reduces and the kidneys sense that as low perfusion and start to secrete more renin and cause the secretion of aldosterone and ADH. And they'll also be quite nauseous as well. So they might say that they have decreased satiety, a loss of appetite, because they've got this buildup of urea in the blood. And then lastly, so there's 2 more things to go. So really common sites for kidney stones. So this is just anatomy. So there are 3 points that you have narrowing of the ureter. And that's in the renal pelvis, at the pelvic brim, where you have the iliac crest and the bifurcation of the iliac artery as well. and then the vesicular-ureteric junction as well when the ureter passes into the bladder. So they're your 3 points that you're likely to get a stone kind of stuck. And they're caused mainly by calcium oxalate stones, and that's because of high calcium in the blood. But there are also 2 other stones. So you can get struvite. So struvite stones come from Klebsiella infections. And you can also get uric acid stones. So that can be from high uric acid. So protein breakdown, gout, things like that. And really the way to kind of treat this is to increase calcium absorption or an analog to parathyroid hormone. Lastly, we've got kind of like the 3 incontinences that we talked about before. So you've got your you've got one that's caused by a buildup of pressure and weakening of the muscle. You've got one that's caused by overexcitability of the muscle, and then you've got one that's caused by an upper motor neuron lesion. So these would probably be pretty good to know. I think they're covered in the anatomy tutes, so always, likely high yield. But also important to understand because next year when you do go out in the hospitals, a lot of the older people will have these conditions. So we've still got acid-base balance to go. How's everyone feeling? Are you happy to continue, or do you want to eat something, get food, get going? All right. Okay, so you've got your pH, 7.35 to 7.45. The easiest way to remember it is remember the pH, remember the bicarb, and the CO2 is just the decimal places of the pH. And that's a really good way to kind of remember it. So basically, to break it down, pH, measure of hydrogen. You've got bicarb, which is there to buffer the pH, and the CO2. So as CO2 concentration increases, it disassociates, and so the blood becomes more acidic. So really, the reason why we have our PCO2 and our bicarb is so that we can figure out if something's metabolic or respiratory. So this is really the formula that you need to know. So it's just saying that you've got, the pH is equal to the bicarb over the concentration of carbon dioxide. So if bicarb goes up, then the pH will go up. If CO2 goes down, then the pH will go up. Okay, so you've got your metabolic acidosis, so that's your first one, and that's a change in your body that decreases the plasma bicarb. And by doing that, that will decrease the pH, so it'll increase the acidity. So I've gone through one of the main conditions here, which is lactic acidosis and how it happens. But pretty much when you get this lactic acid buildup because of anaerobic respiration, the lactic acid ends up being buffered by the bicarb. This reduces the amount of bicarb, and because of that, you get a lactic acidosis. And you can also get this from sepsis or shock and from hypoxia caused by COPD or an acute asthma exacerbation. There are also different types of acidoses that you can have, like ketoacidoses or acetic acid acidoses, but just know lactic, because that's probably the main one. So there's this kind of idea of something called the anion gap. Is anion gap relevant for you? Do you know? Have you learned it? Oh, are they? Cool. Sorry, I came over from postgrad, so all my stuff is from last year, but this is what we've remembered, but it's within the same. So this idea of the anion gap is basically saying that you've got sodium, they make up your positive ions. You've got chlorine and bicarb, and they make up your negative anions. But normally in the body, there's this number of 12, which is a magical number, and this is your anion gap. So this is something that can't directly be measured, but we know it exists because the body exists in equilibrium. But what can happen is there can be certain conditions that cause a decrease in this amount of protein that's floating around in the body, and that can lead to what's called an anion gap acidosis. So basically, all you need to know is if you get an anion gap and it's higher than 12, just know that it's because there's an exogenous acid in the blood. So what that means is either the person has ingested salicylic acid, so like aspirin, or the endogenous levels have been increased, like lactic acid, or you're losing bicarb because of GI. So when you have diarrhea, what can happen as well is you can lose the bicarb that's secreted into the duodenum, and because of that, you can get an anion gap acidosis. And this is just a mnemonic that's in there just to show you like what can cause a change in the anion gap. Probably the main ones to know are DKA, uremia, and lactic acidosis, and drinking too much alcohol. And then you've got your normal anion gap. So this just means that as your bicarb is being replaced, it's still being buffered with chloride, and because of that, the gap doesn't change. So if we go back to this picture in the top kind of right corner, even though you're losing bicarb, so bicarb might drop to 16, if it's still being buffered by chloride, then there will be no anion gap. But when you have a look at the blood values, you'll notice that there's a decrease in bicarb. So you can still say it's a metabolic acidosis, but there'll just be no anion gap. And now we come to the idea of kind of compensation. So when you have a metabolic acidosis, how does the body compensate? What's the quickest way to kind of get rid of that hydrogen? And the way by doing that is by thinking about that formula. So what you want to do is, if you have an acidosis, you want to get rid of that hydrogen, and so you want to compensate that. And that's just Le Chatelier's principle from chemistry in year 12. So you want to kind of push the movement to one side. So you've got that seesaw, and you really want it to move to one side. Forget that. Now you've got your metabolic alkalosis. So that just means that you're increasing bicarb, and by doing that, you're increasing your pH. So this is really not going to come up. Vomiting is the main thing, and don't worry about saline sensitive, saline resistant. So how do we get this in vomiting? So because we're losing our hydrogen ions, we're becoming more alkalotic, but also there's this kind of like interesting thing that happens in that the pancreas doesn't sense that you're losing hydrogen, and because of that, it doesn't secrete bicarb, and that also increases bicarb in the body. So you get an increase in the pH plasma. And the best way to remember kind of one of the main factors of metabolic alkalosis is that you have a hypokalemia. So just remember that mnemonic at the bottom and you won't forget it. Don't worry about saline resistant as well, sorry. So now you've got this respiratory compensation. So really that's just saying that you want to increase the bicarb, you want to reduce the H, and by doing that, you want to reduce the CO2 production in the plasma. And one way to do that is by hyperventilating, so to slow down your breathing. A respiratory acidosis basically just means that because of the way that you're breathing, there's an increase in carbon dioxide. And because of that, you're going to be retaining carbon dioxide, and that will make the blood more acidic. And now you have these compensations again. So the thing about respiratory compensations is they happen straight away. So if you have an acidosis and you need to blow off carbon dioxide, you can hyperventilate and that can change it. But you can't keep hyperventilating because it's too much energy. So in the long term, your body will use the kidneys to either increase the secretion of bicarb or increase the absorption of hydrogen. But this usually takes days to weeks to months. So really, the metabolic compensation always comes in afterwards. And again, blood pH. And this is really the summary slide. So to think about what happens in bicarb, to think about what happens in the CO2 in the blood, and really think about ways in which the body can change the shift of where things are moving. Okay, I put in some questions there. We can go through it. So we'll start off with this kind of slide. It's about a middle-aged woman. She's got severe diarrhea on vacation, and she's had the following arterial blood gas. So can someone just shout out, what does that pH tell us? Yep. And the CO2? Yeah, it's a compensation. And looking at the bicarb levels, it's a 10. So we can kind of tell by that there's a change, so that there's going to be an anion gap, so it should be about 12. Sorry, I take that back. So really, in a hospital environment, if you do have a bicarb of 10, you would consider that to be a change from the anion gap. Anything from 8 to 14, though, in a textbook is considered normal, just so you know. So by looking at that, what would you call that? Say. And now, which of these statements about the following patient is correct? Like, what do you think that she would be doing? So this one's a bit of a hard one. I'll go to the answers. This one's D, and the reason for that is because you're changing aldosterone levels. So the reason for that is because you have this increased extracellular hydrogen, that drives the fluid in the other direction. That's sensed by the kidneys as low volume, and because of that, levels of aldosterone are increased. And because of that, you lose potassium because that's how aldosterone works. Yeah, a bit of a hard question, but it's good to understand. Does anyone have any questions for me, though? I've chucked in this one as well. I know Manoj is giving you the lecture on hemostasis, but this is really all you need to know for your exams. Yeah. Does anyone have any questions, though? No? Thank you.